Okay, everybody, welcome back. We're going to talk here very briefly about something that is becoming more and more recognized, and that is Peyronie's disease. Now, Peyronie's disease has been known for a long time. However, we're beginning to realize how bad it is. And when I say that, I mean the degree to which this really affects the quality of life of many, many, many men. So this is important. It is something you will see in the clinic. However, the management is a little tricky and generally is going to be taken on by a urologist. So for that reason, do not expect to be asked a whole lot about the details of Peyronie's disease, but do expect to be required to recognize it and to know perhaps the first step in management, but as far as deciding how to treat this disease, you will not be expected to know those particular details. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Definitely subscribe to my channel and you will get notifications every time I put a new video up. Okay, so Peyronie's disease is an acquired fibrotic disorder of the tunica albuginea, which is a layer that extends from the penis all the way down to the testicles. So this layer becomes fibrotic in a particular area, and because of that, it will stretch the penis in one direction or another. And I bet you're probably already thinking, and I'm just going to get ahead of myself, you're probably already thinking, wow, this sounds very familiar. And as a matter of fact, you would be right. This is very similar to Dupuytren's contracture, which you do see pretty frequently. By the way, if a person comes in saying that, my hand's kind of stuck, I can't lay my hand flat on the table, that is Dupuytren's contracture. So even though we don't really know the pathogenesis of Peyronie's disease, what we do know is that there is a pretty strong correlation between Peyronie's disease and Dupuytren's contracture. About 20% of men with Dupuytren's contracture also have Peyronie's disease. So there is probably something systematic going on somewhere. However, it is generally believed that the pathogenesis originates from microtrauma to the penis, just ordinary trauma that you would get from sexual intercourse. So it's probably a little bit of both. There's probably some people who are susceptible genetically, who then develop Peyronie's disease from some sort of trauma. The prevalence is estimated at about 3 to 9% of the male population, so this is pretty common. And it usually affects men in middle age, so 40s, 50s, 60s. There is also a common association with erectile dysfunction. About 20 to 50% of men with Peyronie's have ED. So we don't really know why this is either. It's possible because getting an erection can be painful for these patients. They may subconsciously not want to get an erection, even though the time is right. But we don't really know. And in many instances, we do have to treat the erectile dysfunction alongside the Peyronie's. The deformity in Peyronie's is progressive. It does not self-resolve. So basically what happens is they start in this active phase where the primary symptom is penile pain. And what they will notice is that their penis, when it's erect, is starting to turn in different directions. And that direction can be biplanar. So it could be, let's say, in the sagittal direction. So here's the patient's head and here's their penis, like that. Or it could be in the coronal direction where, let me see how to draw this. Well, basically left to right. So their penis would curve like that. So to one side or the other, right or left. So it can be in both planes. Now, the stable phase is when there's no change in curvature for 3 months. And at that point, the progression is pretty much done. The manifestations, like I said, penile pain early on in the course, dyspareunia, both for the patient as well as their partner. As you can imagine, if your penis is not in the right direction and you're pressing up against something, it's going to hurt. If you have a penis inside you that is not in the proper direction, it's going to hurt. So this can be a problem both for the patient and for their partner. And it can also, of course, cause psychosocial distress. But the pathognomonic sign, what I want you to get out of this is that there is a raised, firm dorsal plaque that is palpable on the penis, especially in the erect state. The diagnosis here is to give an injection into the corpus cavernosum to trigger an erection, and then look at the penis under duplex ultrasound. You will be able to appreciate that plaque. The management, this is going to be managed by a urologist. You are not going to do this as a primary care provider. Your responsibility is to recognize it. If you've got a patient coming in with obvious Peyronie's disease, send them to the urologist. They will take care of everything. However, it is useful to know that ultrasound is an important part of our diagnosis. If there is pain, NSAIDs are warranted. And as far as therapy, there is non-invasive therapy, which we usually go to first. And what we use is a collagenase. This collagenase is still on the market as Xiaflex. I think it's called Xiapex in Europe, but Xiaflex, it is a collagenase that is derived from a Clostridium species. So that's kind of interesting, but it basically breaks down collagen. There is surgery. It's called tunicoplication. You don't need to know this stuff. I just put it in here so you have an idea of what goes on. What you need to know is how to recognize this and what to do. You need to do an ultrasound. You need to appreciate that plaque. Otherwise, you're sending them off to urology. Manage the erectile dysfunction as appropriate. PDE5 inhibitor, there's some indications that this can actually be therapeutic for Peyronie's. And then psychotherapy, many men will need this psychotherapy because for some men, it's thought that the erectile dysfunction kind of plays off the pain. So naturally, if having an erection gives you pain, you're subconsciously possibly not going to want to get an erection. That can cause ED even after they're treated. What's not recommended, there are a variety of things that have been thrown out there. Vitamin E, tamoxifen. It was thought that some of these can interfere with the deposition of collagen, but that's pretty much been debunked. So I wouldn't use any of these. And the AUA would guide you not to either. So to recap, Peyronie's is an acquired fibrotic disorder of the tunica albuginea resulting in abnormal curvature. It's most common in men over 40. Look for 50s and 60s. Pretty big association with ED, which needs to be addressed alongside. There's two phases. Acute is marked by pain and increasing severity of the curvature. Chronic, you have stable curvature, but all the other symptoms that come along with it, like dyspareunia. Aside from the visible curvature, the most characteristic feature, and this you've got to know, is a raised firm plaque on the dorsum of the penis. Refer all these patients to urology. You can diagnose this with intracavernosal injection and penile ultrasound. Non-invasive management is with a collagenase. Invasive management is tunicoplication.